Today's COVID update is brought to you by Fulltech Systems, your technology center, where you'll come for the price but stay for the service.
And we're back, and this is our COVID-19 update for today, brought to you by Fulltech Systems Limited. We are talking about COVID-19. And there are quite a number of issues to be able to discuss. And we're joined at this time by internist at Belize Medical Associates, Dr. Fernando Cuellar, to address the latest, the statistics, the risks, and what we know. We have him on the line with us. Good morning.
Good morning.
Good morning, guys. Good morning.
All right.
Morning, Belize.
Now, Dr. Cuellar, we are, of course, talking this morning about a lot of issues that are related to COVID, but primarily about those that are affecting the frontline workers in the medical community, and of course, in particular, doctors. Now, we have, of course, heard the tragic news about both Drs. Guerra and the more recent passing of Dr. Baldomino Barboza due to COVID-19 related complications. And perhaps we can start our conversation by you giving your reaction to those events and putting some of the COVID related issues in, or the issues that we'll be talking about in context.
Yes, thanks, Gavin. And indeed, it's been a very tough, perhaps past month or so, because we've been hit directly in the medical community. We've lost both Dr. Guerra's young physician, really promising future ahead of them. And they have actually fallen in the line of duty. And most recently, we've lost Dr. Baldomino Barboza, who has given to this country 40 years or more in service to the Belizeans through his medical profession. So we're touched right where it matters most, in the heart and spine, to have lost our colleagues. I want to quickly add that we've also lost another colleague, not specifically to COVID, but nevertheless a very debilitating, very an illness, very disheartening, Dr. Alba Mendez. So I just want to quickly mention her name, that it's a blow to us in the medical community. And as we were saying just before we went on camera, and I want to hopefully highlight it a lot during this conversation, is it's not just the doctors, of course, it's the whole medical team. And if I am forced to single out any particular member of the team, I would think the nurses would be the one who would deserve more credit more than anybody, because those are the ones who interact most with people who are sick with COVID. I want to give you my honest personal experience since all of it started. And what I want to say first is that when this started in March, I can remember well, it was perhaps when it was declared a pandemic. It was around the same weekend that Kobe Bryant died or lost his life in that tragic helicopter accident. And the following week, what I was forced to do personally is to go and check on my will. I did that. I went to my attorney. I asked them to see if we needed to do anything else to the will. We checked it to make sure that my dependents, my kids, my family would have been well taken care of. Something had happened to me. And that was the first thing I did. At the time, there was a lot of unknowns. There's still some unknowns about COVID, but we felt that something terrible was coming on to us. So from a very personal standpoint, that's the best thing I could have done to make sure that those persons I love would have been well taken care if something had happened to me. The other thing, of course, is to read, inform ourselves, keep up to date. It was and it's still amazing the amount of reading and learning we have to do on a day-to-day basis. We don't have time to read every article that comes out, but we are still connected around the world. We are connected. I, for example, connected to people out of Mexico, out of the US. We hear about the experiences. We see what's in the literature. We try to keep updates so that we can indeed be prepared to attend to people with COVID.
It's a very practical, sorry.
Go ahead.
No, I was going to say it's very practical advice that you're giving, or I think using your story as an example to ensure that things are in order for your family when you're facing such a threat. And if we do go back to that time, very early in the pandemic, we know that internationally, the frontline workers were severely impacted from the start. And it was a lot of things. It was shortage of equipment being one of the most critical ones. We heard all the stories of people reusing masks and trying to sanitize them themselves. But I'd imagine that some of those things perhaps have been mitigated over time. How do you describe what the risks are today for physicians, nurses, all medical professionals who interact within hospital settings?
Yes, that's a good question, Marley. And it's ironic if I tell you that attending to patients in the COVID units, either the ones that are referred to as moderate cases or the severe ones or the intubated ones, that is when you most protect yourself, ironically. You're going into the room, you put on your PPE, you protect yourself very well. You make sure that you left your stethoscope outside. You make sure that you left your telephone outside. We take off our watches. So when we go into the units, that's when we're most protected. The problem arises is in the asymptomatic patients, people who you see in your office, people who you see in the emergency room, who come for different ailments. You can't say who has the COVID virus and who doesn't. So many times it can be very unassuming when you attend to these patients. I've had many close calls with patients in emergency rooms that would come for issues seemingly totally unrelated to COVID. And when you swab them, they're COVID positive. So it's a universal precaution that we have learned to do. It's almost second nature now. Mm-hmm. We have on our mask, the proper mask, wear it the proper way. Most of us now use a face shield all day long, pretty much. And if indeed anybody would show any signs of any respiratory ailment, then we would put on a little more extra protection. But our fear and my experience is people that I see in my office, people that I see in emergency room that are not known to be COVID, and that's when we get catch. And it's a pity my colleague didn't come on air, because they would tell you those who have also, because quite a number of us have been COVID positive, but have recovered, and they would tell you that they wouldn't be able to know for sure where they got contaminated or got infected from. It's just seeing people on a regular basis.
Yeah, but of course your risk for exposure increases because of the number of people you come in contact with. Is there any, I know there was talk and research is still ongoing on this new disease, but they were looking at things like viral loads and frontline workers and how much they're exposed to.
Right. That's exactly what I was saying. There's a lot of discussion that when the person is most contagious, it's during their early days of having themselves before they start the symptoms, actually. Mm-hmm. So if you start with your cold and your stuffiness and your sore throat today, perhaps the day before was when you were more contagious. So that makes it even a more threatening situation. Mm-hmm. So we do have to be very careful all the time. And like I said, I have been caught in some near call situations and thankfully, I have not yet been affected. I think just this week, though, I'm going to do what we call antibodies to myself to see if have been exposed already without even knowing it. So that will happen this week, and I know that in Belize now we're going to start to do the antibodies so that people can know if they were exposed. And please let everybody understand, it's not to diagnose COVID. The diagnosis of COVID is through the rapid test and through the PCR, but in terms of to see who has immunity, it's when you test the antibodies. And of course, if you know, if you're in upkeep with the discussions, we're talking about vaccines that will eventually come on board in a very, very near future.
And Doctor, you had mentioned earlier that you yourself have had some close calls with the virus. So I'm wondering if you could describe sort of what it's been like for you and other frontline workers and medical professionals in the hospital setting, having to deal with those things, having to deal with so many close calls. One, the amount of or the measures that you yourself will have to take personally, and I'm also wondering how often it is that you're being tested, because we know that a lot of people have had to be tested frequently, and that's not the most comfortable thing, getting the nose swabs and stuff. So can you describe what your personal experience has been like with those close calls that you've had?
Yes, I think I've been swabbed at least 8 times already for this pandemic. I don't find it uncomfortable. Again, I'm kind of used to it. I even joke along with my colleagues and tell them that it gives me pleasure to be swabbed. Because after a amount of times I've been swabbed already. The close calls, the biggest one that comes to mind right away is somebody showing up in emergency room at 2 a.m, having severe difficulty breathing, and have to attend to that patient without knowing for sure their COVID status, but still assume that they have. Nowadays, if you sneeze, you're more at risk to be diagnosed with COVID. So that was perhaps one of the biggest problem. The biggest example I had attending to a person at 2 a.m. that had come from Corozal, having severe respiratory distress, and I had to intubate with all the precautions. Like I said, sometimes we double mask. We have our face shields. We have something called a hood that we would use to intubate. Honestly, it didn't even give me time to get the hood. And we have a even fancier thing called a video laryngoscope, where we don't have to be directly in the face of that person. We could, it uses a video, but we didn't have time. It was a life and death thing, and we had to act. And that is when sometimes we do have to put our personal, our lives aside and try to help somebody. The other things is a little bit more or less dramatic. We would see people, and I would see persons in my office, and they would describe symptoms that are not too commonly associated with COVID, like diarrheas, like vomiting, and then you will get suspicious, but already you're in contact with them. Mind you, the practice of medicine has changed quite a bit in the office setting, in consultations. If you would see the layout of my office now, the chairs are pushed way back to the wall. We're trying to get that 6 feet distance. The examination of a person has changed, unfortunately. I haven't reviewed somebody's throat or neck area or come that close in months now. And I would tell them that I would not do it because of the same COVID thing. If you come for consultation for a knee problem, for example, it would have been tradition or probably even obligatory for me to take a blood pressure, to listen to your heartbeat, to listen to your lungs, even if you come for a knee pain. That isn't happening so often again. So indeed, the practice of medicine has changed because of the COVID. So that's definitely how things are at this point. We also try to take care of ourselves, just like we preach. Take care of ourselves. We try to eat healthier. If the camera would catch, I have at least 6 bottles of vitamins right beside me. I try to keep up with my vitamin intake, the ones that are recommended overall. I do go through, perhaps over the past 3 months, I do use preventative dose of ivermectin that I've started over the past 3 months. Once the literature came out a little bit stronger, that is helpful for that. So I do things that would definitely protect myself. And one of the things I can say now, different from before, I'm not scared. I'm not scared. Fear is not in me now when it comes to COVID. I am conscientious of dealing with patients, but I'm not scared. I'm not scared to go into the COVID unit. I'm not scared to intubate somebody. I'm not scared to take care of somebody who's intubated, and we've been doing that. So thankfully, at least that first 3 months that there was the fear of the unknown, I personally have overcome it. And I feel very comfortable now dealing with patients with COVID.
Yeah. I mean, we've learned a lot in the first year. And of course, in the second year, we're still trying to get it contained. I know earlier this year, the medical associates started treating COVID-19 patients. How has that been going, and what are you seeing that are noteworthy?
Yeah, definitely. Like we would like to have used the word fluid. It has always been a fluid situation.
Yeah.
We saw perhaps a couple months, 3 months ago, that the ban for taking care of COVID patients, of people requiring hospitalization, the moderate cases and the severe cases requiring ICU, the demand was too great for the country, and more bed availability, more help needed to have done. So we as a company decided to expand, to rearrange our hospital, so to speak. And rearrangement come with one car, so there was quite amount of money invested to rearrange 3 rooms that we were able to design to be able to take care of COVID patients.
And the patients that you're seeing, are they of a specific demographic? How severe? I know one of the concerns is that people don't go to the hospital until they're already in respiratory distress.
No, in the private setting, we're not getting those. We are getting people who are moderate, mostly. Moderate, mostly, that require oxygenization and other dexamethasone, ivermectin, remdesivir, those kinds of treatment. There have been only a few that have deteriorated in spite of being hospitalized after a day or 2 requiring intubation. And unfortunately, we have had a death after intubation. So in the private setting, it might be a little bit different, that we're getting patients earlier. And it fits the same demographics as we see in the rest of the country. Males getting more affected big time. So I wonder if this virus wasn't designed by a female, perhaps. But we're definitely seeing more males being affected. We're seeing the same age groups, and it doesn't discriminate against social status, and it does not discriminate against how much money you got. So that's why we should all, as Belizeans, realize that it will take us a team effort as Belizeans to stop this virus, because it does not discriminate. I've had the unfortunate experience. I have to attend to one of my colleagues had fallen ill and required a whole week or 8 days of hospitalization. And for a moment there, it was rather worrisome for that colleague, for her to get recovered. No? But thankfully we did.
Yeah.
So, but at some point, I do want to highlight not only the physician, like I said at the beginning, the nurses. I look at the nurses, and when they're in those COVID rooms, in those PPEs, 24 hours or 12 hours as the shift require, it's a hell of a toll on them, no? Yeah. They sweat, they have trouble getting to the bathroom, eating, simple things that one would take for granted. Mm-hmm. And of course, the risk is higher with them because they are more in continuous contact with the patient. For example, in the private setting, and I know even at College at some point, we have a surveillance system where I have cameras in the room where I don't have to go into the room often. Mm-hmm. And we can be watching our patient, even from my office sitting down, through camera system, watching their numbers, watching how they're doing, watching how they're breathing, watching how their SATs looking like, watching how the ventilator is behaving. So we have the in-house telemedicine, and the other private facility also have it. And COVID unit in College have it to a large extent too. So the doctors themselves don't have to go into the room very often. I would see patients in the COVID areas maybe twice a day, unlike what I would see patients in a room for other ailments. But it's the nurses who have that one-on-one 24-hour contact that I am very, very...
It takes a team, right?
Definitely takes a team. Now, the X-ray technician, the lab technician, they have to go in and draw blood. They have to take an X-ray is an important day-to-day tool that we use, and the X-ray technicians, they have to go in and deal.
Is it still mostly the lungs that you see affected?
Still mostly the lungs, but it's not just the lung tissue itself with the pneumonia, but the clotting, the blood clotting that's happening in the lung. We're seeing that, unfortunately, that still poses a big challenge in terms of getting that under control. So it's a dual thing, taking care of the pneumonia itself, which is the infection that affects the lung tissue, and taking care of the blood clotting that is affecting the blood vessels that is feeding the lung. So it's a dual thing, and I mean, we have learned that we need to treat aggressively with blood thinners, and not just the antibiotics and the antiviral, because there's not just one single magic bullet. No, it's a concerted effort. We have to make sure that person fluid levels are good, the urine production is good. We have to watch the liver function, because even the same medication that we give sometimes may affect your liver. So that is daily monitoring.
And how optimistic does the news of the vaccine or vaccines on the horizon make you when you think about moving forward?
Very optimistic. I'm happy that we are well on way to get it in country. One of the piece of information that we will have is that not just because the vaccine will land in April means that everything finished. No, we won't see the effect of the vaccination till months after. So we will still have to have our guard up, perhaps the rest of the year, before we can achieve that famous herd immunity through vaccinations. So it doesn't mean that after 1 day or 1 week after vaccination, that's the godsend and everything will just magically disappear. No, we'll have quite a bit of time still ahead of us, practicing the same measures that we're asked to do. No, the proper face, the mask wearing, washing hands, and social distancing.
And, on that point, I think one of the things that we have heard from you repeatedly, you've been very blunt in speaking to the public about adhering to all the protocols to prevent further spread. Currently, as of yesterday, I think we had 20-something new cases. Our positivity rate overall is still around 20%, but that's down from the 21, 22 we were seeing before. Do you get concerned about the fact that when things start looking good, that people start getting more complacent?
Yeah, that's a huge concern, and I'm part of the group that would look at the data and make recommendations.
Yeah.
I can't officially speak on behalf of them, but I know that they won't have any problem for me to mention, because it's still public need to know that although we are seeing a slight decrease in numbers, we're not taking our foot off the gas pedal as yet. No, measures will still be in place, and we still, for example, we just had perhaps a super spreader event with the Christmas and New Year's, and you know that after that 2 weeks you have hospitalization, and the following 2 weeks you can see an increased number of deaths, because that's the trend that's happening worldwide. So we still have a month at least to expect the worst, and we have to be prepared for the worst. So we can't relax our measures as yet. We can change our strategies a bit, which is a dynamic thing, and that's why we meet and discuss, and we change depending on the data we're seeing.
Yeah. And what about the new variant that was detected in the UK? Yeah.
We already started knowledge of this and surveillance. There's a connection to entity outside of in the US that we are testing the samples we have to see if we can pick up any of the new variant. And even that, it was discussed of what we're going to do with travel in terms of trying to avoid the new variant, or try to minimize the possibility of the new variant coming in into the country. So one of the things I think I'll be recommending to our team is that we need to get out there a little more to tell the public what's happening, because I was listening to the talk shows and over the weekend, and they're asking me questions, and they're not fully aware that a lot of things is being done, especially as it comes to, for example, the new strains, and what measures are being taken, what surveillance, what genome testing is done on the virus. I will tell you.
So we do have constant surveillance, just to understand clearly. We do have now surveillance happening to test the strain. We send it outside to be tested.
Right.
And we haven't.
Yes, we have. It started. We were not doing it as intensely as now, but we definitely, we can't do it in country. We can't test the strain of the virus in country. So a lot is being sent to Baylor in the US to help us test the strains and see if we can pick up indeed if there's a new strain. We should assume that it's not if, it's going to be when we're going to get the new strains here in Belize.
That feels like February 2020 all over again. That's what we said about getting COVID in the country. The issue with this strain, though, and maybe you can help us understand more. I know the WHO calls it highly problematic, because where the variant is known to be more infectious, it's not necessarily going to get you more sick. But more sick people does mean more severe cases as well.
Excellent point, Marlene. That's exactly what we're seeing. You know? It was kind of said at the beginning now that, it's only more transmissible, or it's only more infectious. But definitely if we get more people getting sick, there will definitely be more deaths. So it's still something we have to pay attention to big time. Okay. And we are hearing encouraging news, for example, that some of the vaccines are still very much effective against the new strain. So that's encouraging. So that is something definitely that will benefit all of us, the vaccines.
And just to return quickly to one of the points that we were discussing earlier, when you were mentioning talk of the healthcare workers, such as nurses, going through their longer shifts and using their equipment and stuff for long. And I'm just wondering if you can describe sort of in a general context where we are in Belize with COVID, just about where we are with the resources, with our medical resources, because a few weeks ago when there was a large amount of hospitalizations and some of the conversations we were having, some of the doctors described the situation at the time is that we were almost at our limit. Yeah. We were at capacity, and that our resources were almost, fully, accounted for. So I'm wondering if you could describe what the situation is like today, both for the where the healthcare professionals are concerned, and also other sort of resources such as equipment and stuff like that.
Well, we don't even have to say other doctors. I think I was one of the main ones who was sounding the alarm that we had reached the bursting point, that we had already burst. No? Mm-hmm. Right now, as we're speaking, the view is a bit different. It's better. We don't have as much hospitalization. There's been a number of work done to increase capacity levels in the districts. They've been training to other doctors and teams to be able to take care of the more ill patients in the districts. Even at Carlucia, there's been quite a number of changes to absorb higher capacities. We don't hear as much. I'm sure that from time to time you might have the one or two, but we don't hear as much complaints about not having equipment, PPEs. We have ventilators and things that go along with ventilators a little bit better than before. So as we speak right now, in the second week in January, we are definitely in a better place. And even to absorb any other little surges that might come in Belize. Yeah. We have definitely, one of the things I have been satisfied with, the public-private collaboration is much stronger now. For example, I am on a chat group that receive information from the districts. I'm not employed with the ministry. I'm a collaborator.
You're on the medical expert team.
Yeah, there's too much teams, and if I would complain about anything, Marlene, there's too much chat groups and too much chat, because what you're referring to, we have another one, for example, that just look at the clinical part. So last night at 9 o'clock, I got information about 3 or 4 patients at the Western Regional. The doctors there are asking for suggestions and recommendation and help, and I'm able to help with that. Yeah. And one is going to be transferred to Carlucia this morning. We're going to start with them in Berziver and the other 2. So there's a lot of collaboration amongst the public and private, which I am very happy about. Even myself, Hidalgo and Arega, who are the intensivists, we share even the private patients' management between ourselves. We are very much involved with Dr. Barboza's care, the 3 of us. Even though we're not physically at that one site, they are involved with patients that I see here at Carlucia, the ones that are troublesome. So we're making that collaborative effort for sure. And I think that will pay off big time.
I mean, that's very promising. I think it's important that professionals in general are able to consult with each other, especially when problem solving something in the unknown. Just out of curiosity, I know that we are limited in what kind of data we can collect, but are there any trends in Belize from your own experience or from talking with doctors as to what we know of who tends to get more severe cases? You noted men earlier, but is there anything else that we are seeing? Obesity,
diabetes, hypertension. Okay. And don't take this to task. Don't say this is etched in stone. But for some reason, we've noticed it ad hocly. For some reason, something is happening in the north in terms of the aggressiveness of the virus from up north. No, we say it. We've noticed it over the 2 handful of patients we've had, that we noticed that persons from the north are definitely more. Somehow the virus behavior is a little bit more aggressive. We don't know why. We are looking into that, but that is the only uniqueness for Belize. Other than that, we are following just like what we see in other countries. No, males, the age group, the comorbidities that are more affected.
Any word on the blood type? I know that was one of the things people were looking at one point.
Yeah, no word on it. That whole thing with blood typing, that's not specific to to COVID, there's theories that blood types are associated with different illnesses, but that definitely hasn't had any evidence to support that. There are some reports, anecdotal, I would say, and I wasn't surprised when that came out that it was going to be suggested that some blood types are more linked to COVID, but that hasn't had any hard and fast evidence. So we don't
think
use
because
that.
you have a particular blood type, you're safe.
Exactly. We don't use that. We don't test somebody and say, oh, well, you're O positive, you more than likely will be intubated. No, that doesn't have any strain of evidence to support that. What we look at is the age, the comorbidities, the obesity, and that the same things we've talked about all the time.
Now, what about treatment for people who have tested positive? We know a lot of people are relying on natural remedies. There, fever, grass tea, a whole bunch of stuff that people take if either as preventative or if they know they have tested positive. What's your advice there?
My advice there is that you can indeed take your home remedies. The vervain, or is it the way you pronounce it, the vervain or the fever grass, you can take it, but that does not substitute for medication, no?
Yeah.
So you can take both of them, and indeed these natural things do have antioxidants which help fight diseases. So I don't stop or I don't discourage people from taking their natural remedies. Myself, I think for a long months I was taking. Some people actually came to me with gallons of things. I said, Doc, we want you to be well. We want you to take care of this. And this one, the best one that exists in the world, the turmeric and the garlic and honey, things that really taste bad sometimes. But I used to take it. Yeah. Not, of course, forgetting that I have to also take my vitamins and protect myself well. Yeah. So I don't discourage people from taking the natural remedies.
And so if someone tests positive, yes. And if I test positive today and I have mild symptoms, maybe just a sore throat and a headache, what type of medication should I be on? Not everyone goes to see a doctor, and a lot of people treat at home. They may take, the natural remedies or nothing at all.
Right. Well, it's unfortunate that everybody. I will encourage first and foremost. Get that checkup with a healthcare provider if you've tested positive and have mild symptoms, because this disease is a monster. It can turn on you from one day to the next. Yeah. But if you absolutely refuse to go see one doctor or a nurse or the hospital, then there are a few things you would definitely make common sense suggestions. No? Mm-hmm. Be properly hydrated, rest. You can get your vitamin B, vitamin C, vitamin D, your zinc, and aspirin, Tylenol for fever. And what we've agreed to recommend is that you take ivermectin, people with mild symptoms even. There was a lot of questions and believe me, it didn't come out that way. Left ears or right ear just to recommend ivermectin like that. No, we looked at the data, we looked at the evidence. I, for one, given the amount of medical training I've had, I would have sworn to you that 10 years ago, I would have not even considered evidence that is not done through what are called randomized controlled trials, which is the gold standard for evidence in medicine. But a lot of these drugs, the repurposed drugs as we call it, have shown some effectiveness alongside the fact that they are not harmful and they're accessible. So it's not just that we measure the effectiveness, but we also look at it's not harming somebody. Yeah. So you can recommend it. Curiously, I was on the way here at the office. I have lived enough to have gone through cholera. Anybody remember cholera?
Yeah, I remember cholera.
Maybe you're too young.
No, I remember it.
Cholera and then Ebola, no?
Yeah.
Were the two big things. And we had also issues with dengue, for example, no? Yeah. We had some severe issues with dengue some years ago. So we've had our medical issues here in Belize.
How
But
do
this
you-
one, honestly, guys, this one a monster. This one knock you down, wreck you up big time.
Yeah. And I do want to talk about those long-term effects that we've had people here explain. I mean, Dr. Manzanero is a great example, but there's several others that we've talk about long-term effects. But before we get to that, let's just address one of the issues here with now the recommendation of using medication like ivermectin. This is a new disease, and so information is kind of released as it goes along. The studies start, you get some preliminary data, then you hear, oh, it won't work. Hydroxychloroquine is a great example. When you have your patients keeping up with the data as it goes along, I'm sure it builds a level of skepticism as to whether or not they can trust. You know, you say, Doc, first you said not to take it, now you're telling me take it. What's going on here? How do you explain this to people?
With the truth, Marlene, with the truth. I mean, I would approach it like that. I tell them, listen, maybe 6 months ago we were not recommending. The data has changed, and now I'm recommending. Definitely, like for example, I can tell you some other drugs as simple as Tylenol. 15 years ago, there was a different amount of Tylenol you could have taken in a 24-hour period. That has changed. Mm-hmm. So everything changes as evidence builds. And but for sure, things like hydroxychloroquine has not shown any difference as opposed to when it was in March, April, or May then. But the ivermectin has shown with some data that it's helpful. And like I said, we look at all the data that exists, examine it and say, yeah, this is something we can recommend. Yeah. And I do appreciate the skepticism that can come out of these things because we said one thing, but I can quote you that even Dr. Fauci, who is Jesus Christ on earth when it comes to these infectious diseases, his rhetoric, his talking has changed over time, and we just have to work along with it. The remdesivir, for example, came out. Some said it was working, then some said it wasn't working, and now it's working back. So we're recommending the use of that. Yeah. But it's understandable. We shouldn't get upset with each other when we have these conversations. It's very understandable that it looks like we are shifting the goalposts from time to time. But indeed, as the evidence come out, that's what we need to do.
Yeah. And speaking of skepticism of certain treatments, have you also dealt with any skepticism about the virus in general? Because as we know, if we look at news from other parts of the world in particular, and even sometimes locally, people say that the entire COVID thing is a hoax, and people refuse to wear masks and something like that. And I'm wondering if you've had any experience with or first-hand experience with people like that, maybe through the hospital or just in conversation.
No, that's curious, Gavin, as you asked that. I have never met any Belize that would tell me that the virus is a hoax and it's a make-believe and it's some kind of conspiracy theory. I think 99.9% of people realize that this is a virus, it's here, it's dangerous, and it can kill you. I have never met anybody who in Belize, I have read one or two things somewhere, been told that one or two Belizean might still say that this is not true, but 99% do appreciate that the virus is here. Another bigger issue that we have been faced with, and hopefully it's getting less and less, is this issue with intubation and ventilation. No? Yeah. There are a lot of skeptics that say, well, once you get intubated or ventilating, that's it. Better your contact.
That's true. We did hear that and see that.
Better your contact Mr. Lam or Mr. Corey at the same time, because that's it. But that's not true. We, especially in the ICU areas, have learned a lot of different things when it comes to ventilation. We used to manage people on ventilators for different reasons, but this has now taught us new strategies that we need to do. And we know see somebody in any breathing problems and just intubate them so, no?
Yeah.
We go through a process, we increase the oxygen levels, we change the way how the oxygen is delivered to them. You know, sometimes we use the nose thing, we call a nasal cannula. If that not help much, we use a mask with an e-bag, that's called a rebreather. And now, thankfully, we have a thing called a high flow oxygen therapy, which is a new machine with one thing, but it shoot much more oxygen into you, more than what you could get oxygen from a tank or from the wall. No? So those are called high flow. So that's definitely a gap, a tool that we can use before we intubate. And the criteria for intubation have changed a lot, over this past year. We used to intubate people with different criteria. Like, for example, if your oxygen that are 88, 85, we really look for, hey, prepare for intubation. But we have become more permissive. So we'll say that saturations in the 80s, we still try work with them to avoid intubation. And when you do intubate, the strategies you use are far different than before, and it's working better.
Yeah.
It's working better. So I want to tell people in Belize that ventilation, intubation thing has changed a lot, and we are getting better results as we go along.
And
I saw on your program yesterday, Ms. Vega, each hospital have their own good results, patients, and
yeah, you've had people successfully coming off the ventilator as well.
Yes,
yeah,
definitely.
So, and I think that's, I mean, it's medical language that we're not accustomed to either. Intubation is being placed on a ventilator. And what you are saying is that it's when things have deteriorated to a point where you can no longer trust that the body will be able to continue functioning for itself.
Exactly.
Yeah. So,
no.
Yeah, and let's go back to the issue I discussed earlier. Just as we start to close off, the long-term effects of COVID. Now that we've had people in country who have faced this disease at least 10, 11 months ago, we're now able to know that some people are living with challenges long after. What's your experience? What have you seen, or what is the discussion that's taking place around this?
Yeah. A lot of experience with that, Marlene. I'm seeing a lot of patients post-COVID, we call them, or the long haulers. Mm-hmm. One of the main issue with them is this fatigue that they have. No? Yeah. They don't have the energy. They still get a little bit short of breath. That is in a good part understandable, because the virus actually damages your lung, and it can be damaged permanently, can scar it, so your lung capacity isn't the same as before. So that shortness of breath is there, that fatigue is there. I've heard persons with the sharpness in their mind not as good as before.
COVID brain,
Yeah, the fog, they call it. Mm-hmm. We have had patients with kidney disease, with liver disease that have not come back to normal functioning. We've had what are called neuropathies, where they get the tingling and pain in their hands and feet. So we are seeing indeed a lot of patients who have had the long-term effect from COVID. And that will pose one particular challenge later this year, because going back to work, for example, and the extended sick leaves that they may have, it will generate more debate with Social Security and their employers and that kind of thing.
And those long-term effects, they're not just from hospitalized or severe cases, right?
Exactly. And it's surprising, people with mild symptoms who did not require hospitalization still complain of these long-term effects.
All right. Well, Doc, we appreciate the perspective that you shared with us this morning. I think we covered quite a lot, but it is important that we get a view from the front line as to what's happening. And thank you once again.
Yes, I just want to end by again saying kudos to the nurses. Mm-hmm. They are the real frontline people. They are the ones who take care of the patient more than us, the doctors. And please, Belize, it's not the doctors or the front lines that will stop this virus. So it's all of us. Wear your mask properly, wash your hands, and just have patience and obey the suggestions, the recommendations, and the restrictions put in place. And together we are come out of all of this. One of the things then I never like here, and what this thing is, the politicians still politicize this thing, man. When anybody not just behave themselves and grow up and stop talk nonsense and blame one another and that kind of thing, it helps, it not help at all. Okay? So I have to put that in because you know how my mouth goes on. The politicians have to behave themselves.
All right, and you stay safe, Dr. Cuellar.
Okay, thank you.
All right. With that, we're going to go ahead and take a break. That's it for our COVID-19 update for today.
This COVID update was brought to you by Fulltech Systems, your technology center, where you'll come for the price, but stay for the service.